It's indeed an honor to give the Alan Bernstein Lecture. I think, like many of you, I'm a big fan of Alan, and it's a real prestigious honor to have a lecture named after him and to give it. He says hello from New Zealand, where he's on vacation. Let me start with my conclusions, which are really three. The first is that technology, quite broadly defined as drugs, vaccines, epidemiological knowledge, strategies, have been really the key reason for this enormous decline in mortality, particularly childhood mortality in the 20th century. And that these same technologies, through research, will be the key to reducing adult mortality. And I'd like to illustrate that with three specific examples. One is counting the dead, my favorite subject. And the second is around vascular disease, particularly the use of generic risk pills, and the last on tobacco control. And these can be illustrated in the sense of how many deaths can be saved, or how many lives can be saved, and what is the roughly cost of these interventions. So counting the dead and describing death can save many lives, but need not cost very much, about 10 million. Drugs that can be quite widely used for particularly vascular disease can save at least 1 million lives a year, and they might actually be cost savings. And tobacco taxation is actually cost savings and can save a large number of lives. So right throughout, I'm going to give you numbers, and this is the criticism of epidemiologists like myself, that we're number crunchers. I mean, just like accountants. I disagree. I think accountants have more personality than epidemiologists. Well, let's start back before 1800 or so. And this cartoon, I think, kind of says things well. It's two fellows saying something's not right. Everything we do is healthy and the like, but no one lives past 30. There has been an extraordinary change in survival, and this is illustrated very nicely by Gary Whitlock from Oxford's work on what's happened in England and Wales. So these are males at different time periods. In 1860, it was the case that 30% of people born would be dead before age 10, and nearly everyone, about 80%, would be dead before age 70. By 1910, child mortality, or the deaths in the first 10 years of life, had been halved, substantially decreased. And by 1960, there had been a substantial decrease in childhood mortality, but also adult mortality. And by 2000, there has been a substantial increase in survival, particularly among adults. And this is an ongoing process, and it really represents what the evolution has been in global health. So let me contrast now that change in extraordinary change in survival, and I'm going to compare English men to worms to make the case. So here we have the same curve that I showed you, English male survival, basically a doubling of life expectancy, and that time that it took really was about 80 years, or roughly 3 to 4 generations. If we contrast that to C. elegans, which is the most well-studied species that we have, it's about 100 million base pair, 6 chromosomes, 20,000 coding proteins, genes that code proteins, and we really understood this well. Well, through a series of experiments that knocked out different types of lipid metabolism genes, it was possible to extend the life of the wild type, the natural type, to almost this tripling the life expectancy. And these experiments took 160 days, or basically 5 generations. And importantly, this change is dramatic, but was very fragile, meaning some other conditions, such as the pH or other values, would actually dramatically vary the survival of the mutated type. So the contrast here, comparing English men to worms, is really to make the case that the extraordinary survival increases that we've seen are really a result of public health, and they nearly exceed what we can achieve in a very controlled clinical or even a laboratory or a basic laboratory setting. And moreover, the survival is much more durable in humans than it is in worms. It's much less subject to these kind of changes that can affect the survival in a laboratory. Well, what's behind this extraordinary change? There are different phenomena occurring in different time periods. In the first half of the 20th century, mostly it was from the control of infectious diseases. That included identification of the modes of transmission, but also early vaccines and drugs. One of the most important ones was the Jenner smallpox vaccine, which was actually done in the 18th century. In the latter half of the 20th century, it has really been from specific interventions that have been scaled up. This is where public health married intervention knowledge and transmission knowledge, and we actually delivered interventions. And these are some classic examples, smallpox being the most important one. It used to kill 3 million people a year. My late grandmother in India had a total of 12 children, and she lost 2 in early childhood, and one of them was to smallpox. And I told her just before she died that, did you know this disease has been eradicated? And she was stunned that that had been achieved. The extended program in immunization has taken the percentage of the world's kids that used to be immunized for routine immunizations from about 10% up to about 80%, and has been extraordinarily effective. Oral rehydration, born of research out of Bangladesh, has substantially reduced diarrheal deaths. And malaria control outside of Africa has been also an example of success. This has led to a dramatic decrease in childhood mortality. In 1950, almost a quarter of the children born could expect worldwide to die before age 5. In the present decade, that's down to 6%. And as by contrast, that leads to something like about 8 million deaths out of 135 million births. If the death rates here were the same as England and Wales in the 1800s or Canada in the 1800s, the world would not have 8 million deaths, we'd have 30 million child deaths. That shows you the extraordinary progress. The opportunity is that if the world had Canadian child death rates, then we wouldn't have 8 million deaths, we'd only have 1 million. And that shows you the promise, how much more work there is needed to reduce childhood mortality. Well, it turns out that you can actually look at mortality in a structure which is basically looking at enzymes and how catalytic enzymes behave is very much the way mortality patterns behave. And this is some very nice work done by Ryan Hum, who's my PhD student, who looked at what was the costs, meaning adjusted for inflation, how much money did you need to spend to get a reduction in childhood mortality and adult mortality. And what he's found is that from 1970 onwards, it is getting cheaper and cheaper every year to save the life of a child. See these dramatic declines. Now, why is that? Well, it's very similar to what you saw in the big data presentation, the comparable element of Moore's law. The application of science and technology to wide populations at lower cost has meant that childhood mortality is getting cheaper and cheaper. That's just extraordinary good news for the world. Now, by contrast, look what's happened with adult male mortality in particular and adult female mortality. It is getting more and more costly to save the life of an adult, now particularly for men. Now, some of this reflects the effects of 2 phenomena. One is HIV and the other is smoking. But even if you take away the effects of HIV and smoking, you get a flat line. Now, what does that flat line tell us? It basically says that the same processes that you see in computing or in big data, the Moore's law kind of application where things are getting cheaper and more widely accessible, is not applying for adult health. And simply put, the world has not put the resources into research and the scale up of interventions for adult mortality in the same way that it has for childhood mortality. But the dominant challenge of the 21st century will be to basically get these curves, adult, male and female survival, to also be coming down in the same way. Is it possible? Absolutely. It involves research and scale-up of research knowledge. One of the starting points, of course, is to start with the very basic work, which is to understand what the problems are. And of the 50 million deaths worldwide in low and middle income countries, the amount of information that we have on the causes of death is actually vastly limited. Less than 3 or 4 million of those actually have information on how people die. And even some of the more recent efforts, like the Global Burden of Disease that was published in The Lancet, do not address this fundamental problem of having poor data that does not tell you exactly what the causes of death were. And there was an interesting editorial or journalistic piece done by Gretchen Vogel in Science in June, which I would encourage you to read. The solution, as I believe, is simply to expand counting the dead. The idea of getting good information on how people die, because they don't die in developing countries conveniently at hospitals or in front of a doctor. They die in rural areas and away from medical facilities. So how do we do this? Well, the idea is been described 140 years ago. The Sanitary Commissioner of Government of India said, quote, "For sanitary purposes, it is indispensable to know the relative mortality in small and as far as possible well-defined tracts, and to ascertain the death rates in each of these communities, to see how far these arise for preventable causes, and to apply the remedies." Well, that's effectively what we're doing in the Indian million death study, which involves work with the Registrar General of India, in which we take a nationally representative sample, a true snapshot of all of India. So this is poor India shown in blue, this is more affluent India shown in pink. And all of these states are randomly sampled in about 8,000 small areas, each with about 1,000 people. And in these homes, a true snapshot of India, you send teams with now electronic ability to capture information. They interview the respondent of a household member who had died and obtain simple information on a 2-page form. And then this is available through electronic records through now 500 doctors who are strictly monitored on how they code the causes of death. And there's neat things you can add now, like geocoding of the sites. So this is an example of our work. And we found, for example, that this fellow here didn't actually go to the house. This is a restaurant that he was at to do the field work. So you can get improvement in quality and understanding of information from this approach. Well, what have we found? Things that we didn't expect. Well, first, we documented that there was about 1 million smoking deaths already in India, much more than expected, and I'll come back to that. We've documented there were 200,000 malaria deaths, whereas the World Health Organization only predicts 15,000. And this has led to a rethink about the global numbers on adult malaria deaths. The good news is that we found fewer HIV deaths than had been predicted, and that has led to the change in the government program having less money for antiretrovirals available, simply because the demand wasn't there. And various other findings in terms of diseases that are unexpected. But more fundamentally, what we find is that every disease that is common in one part of India is rare somewhere else. And Indians aren't that genetically different, and therefore these factors must represent some avoidable factors, some either underlying determinants of disease risk or intermediate variables, which await discovery. And let me illustrate that through some examples. But let me, well, I'll skip this slide on malaria. So let's turn to vascular deaths, because this is clearly a focus of this meeting. And starting with the perspective of well, what's happened in Western countries. In Canada, for example, there's been an extraordinary decline in vascular deaths in middle age over the last 50 years. In 1950, the death rate was such that 25% of men could expect to die before age 69. But now that's down to 7%. And similarly for women, 15% could expect to die before age 69. and that's down to 3%, huge declines. And similarly in India, we now are able to see what are the patterns of vascular deaths. So there are overall 1.8 million deaths from vascular disease in India. It's the leading cause of death. And I'm going to focus the rest of the discussion today really on middle age. Now, my definition of middle age changes as I grow older, but I'm going to keep it at age 30 to 69 mostly. So here, what we note is that ischemic heart disease already accounts for about 500,000 deaths a year. And interestingly, a large percentage of those have a prior history, which is very relevant for secondary prevention. And women also have a substantial number, but lower numbers of deaths. And there's extraordinary variation across the states of India. These are the major states of India, which I showed you earlier. And you'll note that the national risk of death among men for heart attack is about 6% between ages 30 to 69. But that goes up to about 10% in Andhra Pradesh and Punjab. But look at these places. Orissa and Assam in the northeast are quite low. They're about 4% or 3%. By contrast, these places, Assam and the northeast of India, have the highest stroke mortality rates. Overall stroke mortality rates are 3%, but these are about twice the national rate. So it is interesting that in the same population, you see enormous diversity. This stroke pattern, meaning stroke dominant and heart attack less, is indicative of the Chinese pattern almost, and less so of the classic pattern that we associated, that heart attacks are more dominant than strokes. And again, the reasons for these aren't clear and await discovery. An important finding from this study was to dispel this idea that vascular disease is if you will, a luxury of the rich. The vascular mortality rates showed a strong educational gradient, such that those that had illiterate levels of education had about 3 times the mortality rate of those that had higher education, both in men and women. And this is important, and I'll come back to why this is important. So what do we do about vascular mortality? Well, as Bruce and we were discussing at dinner last night, in the last 3 decades, there has been a revolution in cardiovascular treatment and prevention, which have taken the big risk factors seriously. And these include smoking, which I will conclude with, but also blood pressure, blood lipids, and obesity. And related to that is the relevance of secondary prevention, meaning taking simple combinations of pills that can substantially reduce the annual risk. I won't talk too much about blood lipids and blood pressure, but let me turn to obesity as the next topic. It is important to note what the evidence is on obesity with the current evidence. So this is a comparison of the prospective studies collaboration, a meta-analysis of large numbers of prospective studies put together by the University of Oxford. And then this is Richard Dahl's, the late Richard Dahl's finding about the 10-year loss of life in physicians that were continuing smokers. And the key message here is that only with severe obesity, meaning a body mass around 43, do you get the same loss of life of about a decade that you do with smoking. So put in more practical terms, for me, that would be gaining something like 100 pounds, 50 kilos more, to have the same impact on my life expectancy as if I were a typical smoker. Now, most of the world, even in parts of the United States which have very large populations, literally speaking, the levels of obesity are nothing like that. Most of the population that we're talking about is obesity around a body mass of 32, and that involves a 3-year loss of life. That's not to say that smoking is 3 times more important than obesity, but it is to say that we know what to do about smoking. We know less about what to do about obesity. Now the caveat here is, of course, this is adult obesity. We do not know yet reliably what would happen if these effects were in childhood obesity that carried on through older age, and that might well have bigger effects. But it is important to keep the obesity and smoking epidemics quite distinct and understand their epidemiology. Well, if obesity is an increasing phenomenon, which it certainly appears to be, we do also know there are ways to combat the mechanism by which it leads to death. So we know how to counter higher blood pressure, we know how to counter higher bad cholesterol, and also to raise good cholesterol, and less about, as you heard in the last session, about the contribution of diabetes. So these mechanisms do enable action. And one of the important actions, which certainly is, I think, a very plausible one, is to try to change the process by which generic pills, particularly vascular drugs, can be made widely available. It is currently the case that if you combine effective generics, you have to basically prove them like a new agent, whereas a more sensible strategy would be that if these drugs adhere to good manufacturing practice and can show bioavailability and shelf life, you should allow their wide sale. What might this look like? Well, again, look at the evidence around combining 3 to 4 generic risk pills in one daily pill, and this slide is courtesy of Richard Peto. If you take a typical middle-aged man, let's say myself, I'm 48, and if I would have had some vascular event or diabetes or the like in the past, any vascular event, my untreated rate of having a stroke or heart attack or dropping dead in the next year, if I take nothing, is 7%. If I had one drug, in this case aspirin, I drop that to 5%. If I had 2 drugs, blood pressure lowering, I drop it to 3%. If I had statins, then I drop it to 2%. The sequence doesn't matter. I can start with a statin and then add aspirin and then blood pressure lowering. But you can go from a 7% annual risk to 2%. And that means a 10-year risk, which is a realistic proposition, a proposition to me that, well, are you willing to take 10 or some combination pills for the rest of your life? And if so, your 10-year risk drops from 1 in 2 of either dropping dead or having a serious heart attack or stroke to 1 in 6. And I think most people would say that's a reasonable proposition. And if you put this in a population perspective, it means if you get 20 million on treatment, you can prevent about 1 million deaths or hospitalizations a year. So it is a widely practicable strategy that ought to be pursued. Now, the other element of this is the equity dimension. Dennis Xavier in Bangalore has done some very nice analysis from a registry data where he looked at heart attack survival in those that had heart attack and followed up, and they were followed up to about 2 months. And so the 2-month survival rate was obviously much, much better in the rich than in the poor, with a strong gradient. But interestingly, he looked at the differences in access to risk factors and treatments. And if you look at the last row, the death rate, once you adjust for risk factors and access to treatment, actually is not different. So again, I think this is extraordinarily important. We don't have many things in medicine that can reduce social inequalities so substantially, yet widespread treatment might well be one of those. Okay, let me turn to alcohol briefly. And the key message on alcohol is don't drink like a Russian. The Russian mortality patterns are quite distinct, and it is one of the few countries in the world where there are more deaths likely from alcohol than there are from smoking. Most of the world is the other way. There are more deaths from smoking than from alcohol. And the reason really involves this pattern of high amounts of binge drinking. And you see that in the national statistics, where this shows the all-cause mortality rate in middle age, or 15 to 44, 54-year-old men. And the death rates are higher already in 1980 than they were, let's say, in the UK. Now, this reflects earlier effects, actually, of smoking that raised the overall death rates. But as things have changed in the Soviet Union or in Russia, then alcohol and overall mortality has changed also. So this is President Gorbachev comes in and he restricts alcohol use. The all-cause mortality drops 25%. Here comes the collapse of the USSR, and Yeltsin comes in And Yeltsin's, as you know, he was selling Yeltsin vodka in Red Square and the like, and the death rate substantially increase. There's a collapse in the economic system with the ruble and a big increase in use of alcohol. And almost all of these patterns can be explained by binge drinking. And an important finding was that much of those deaths that were actually described as vascular deaths were literally people's heart stopping from excess alcohol. And this was a coding error in the Russian death certification, that if you identify those are the causes of death are really due to binge drinking. And what kind of patterns are we looking at? Well, it's interesting to note this study by David Zaritse and others has as the control group men who drank only half a bottle of vodka a week. That's 20 shots a week. That's the control group. And the cases were those that had a bottle of vodka a day. And what they had, so this is 150 shots roughly a week. And what they had was 2 times higher deaths from any medical cause, 4 times for road traffic, other accidents 6 times, suicide, murder substantially increased. And this very much does explain. We see similar patterns in India where among those men that drink 6 or 7 days a week, which we think is a pattern of binge drinking, you see an increased relative risk of death. But among those that drink 1, 2, 3, 4 days a week, you don't see much. And curiously, we find the same patterns, that there is a modest reduction in heart attack risk from drinking, even at high levels, but that is more than offset by the increase in stroke risk, and that makes sense. There might be some effects on the coronary ischemia from alcohol that are beneficial, but the increased blood pressure effects of alcohol will increase your stroke risks. So the net effect on vascular disease in India is no impact. This, of course, has not stopped my father from citing the evidence and having a scotch every evening. Let me turn to tobacco in the last little while. And this is a picture of the late Sir Richard Dahl, photographed at the time that he released the 50-year follow-up of the British doctors study, in which doctors were surveyed in 1950s or so and followed afterwards. And as you well know, Dahl and Bradford Hill did one of the first studies documenting the links between smoking and lung cancer, and their subsequent studies were published in the British Medical Journal. And what they found is really summarized as this, as that prolonged smoking leads to a decade of life lost. This is among British doctors, that the probability of reaching age 90, let's say, which Richard Dahl reached, was 24% for never smokers, but 4% for continuing smokers. Overall, a decade of life lost. But because Richard published these findings in the British Medical Journal, it led to the doctors opening up the results and saying, my goodness, this kills not just patients, but it actually kills doctors. And what they did is quit in very large numbers. And the other key finding from this study was that those that quit by age 40, on average, got back about 9 years of life. So this is Dahl's work, and I'll show you some more contemporary evidence, which is the 21st hazards of smoking. And this took about 60 years eventually to do. So 60 years of epidemiological research were summarized by Brian Williams of NBC News in 22 seconds, and I'm going to show you that.
And good news and bad news on the smoking front. From the New England Journal of Medicine, they say flat out smokers lose at least 1 decade of life expectancy over non-smokers on average. The encouraging news here is quitting before 40 reduces the smoking-related death risk by 90% compared to continuing on as a smoker.
There you are, 22 seconds of soundbite for 60 years of epidemiology. But I want to give you more details of the soundbite. So these are the results from our paper published last month in the New England Journal, which looked at a representative sample of American men and women, and it is among the first to establish the 21st century contemporary risks of smoking. And this is paired with other findings from Mike Toon looking at a variety of cohort studies in the United States, with Valerie Burrell's findings from England in English women, and Dr. Tanaka's findings from Japan, all of which very much enforce what Richard Dahl had documented, that smoking now involves a tripling of risks and about a loss of a decade of life. And importantly, our study was among the first that could study the generation of American women that smoked like men. If you want to describe them as kind of the madman generation, you know, you watch Mad Men and everyone seems to be smoking, including the women. And the women that took up smoking did so 2 decades later than did the men, and therefore the risks that were measured in the studies of 1980s were substantial underestimates. And what we note here is that for both men and women, there's a 3-fold higher mortality among current smokers than never smokers. If you smoke like a man, die like a man, and that's absolutely true across populations. But importantly, cessation, particularly before age 30, returns almost all of that decade of life lost, or in fact, almost all of it. And cessation by age 40, 50, or 60 returns 9, 6, and 4 years of life. Let me just show you some of these in detail. So these are the hazard ratios for deaths by various categories. So women and men are now comparable in lung cancer risks from smoking. That was not the case even as early as, or even as late as 1980s. And interestingly, vascular disease now has a 3-fold relative risks. In medical school, we were taught that vascular disease in smoking was perhaps a doubling of risk. But what has happened is, in part because of those enormous declines in vascular survival from decreases in smoking, from treatments that are more widespread, from understanding of blood pressure, the smokers have not yielded those benefits, meaning those technologies have not offset the adverse effects of smoking, whereas in non-smokers, they're reaping the benefits. And that means the difference between smokers and non-smokers or vascular disease has increased. Respiratory disease is still very much strongly associated with smoking. So this can be expressed in the same way as Dahl had done, which is the survival probability. And women that smoke have only a 38% chance of reaching age 80 versus women that have never smoked. And I think this is a realistic number. It's not true that you're going to live forever, but in the US or in Canada, the idea that you can be in good health till age 80 is a realistic proposition. And it's a 2-fold difference, almost 2-fold difference for women who smoke versus those that don't, and a loss of at least a decade of life. And it's very similar for men. The male risks are higher, even among never smokers. In part, this reflects higher background rates of violence, suicide, including gun violence, but still the differences between smokers and non-smokers is substantial. But the good news is that cessation is highly effective, and those that quit by age, on average, age 30, but the age range of 25 to 34, get back 10 years of life. And even those that quit by age, on average, 50, gain back 6 years. And this can be expressed in survival curves, looking at the never smokers and those that had quit by age 30. And you see the survival curves are very similar. They get 10 years back. And even those that quit by age 40 get 9 years back. So at every year, or every age, there are benefits of cessation, but the clearest benefit is to quit by age 30. Okay, well, Canada and the United States only represent about 44 million smokers out of a total number of 1.3 billion smokers worldwide. So what do these contemporary risks say about future risks in developing populations? Well, they suggest it will be big, and it already is big in India, where our finding from a retrospective study notes that the men who smoke bidis, which is a small locally manufactured cigarette, lose 6 years of life. But the men who smoke Western cigarettes are already losing 10 years of life. Currently, few women smoke in Asia, but that may well change. It did change in the United States as a result of the Virginia Slims kind of advertising. But women seem to lose 8 years of life among those that smoke bidis. In Bangladesh, which is nearby, you see similar patterns, about already a 7-year loss of life among the typical smoker in Bangladesh. And in China, which has been very much mirroring the US, the effects of smoking are only now starting to be seen. China has the world's largest numbers of smokers, about 320 million Chinese men mostly, and some women smoke. And the estimates of the hazards in 1990 suggested only 12%, and of all of the deaths were due to smoking in middle age, whereas the correct projections are by 2030, which should be about a third, which is exactly the patterns in the US, but just 40 years later. And this underestimation is quite important because it confuses politicians and others thinking, well, smoking kills Western men, doesn't kill Chinese men. And local epidemiological evidence led by Zhenming Chen and others is really going to be important to try to refute that, misinformation. The concerning news in China is that many of us had thought that the worst of the consumption had actually peaked perhaps around 1995 and had started to decline. The World Conference on Tobacco Health was held in Beijing in 1999, and there was some optimism that overall cigarette consumption had decreased. But since that time period, it's gone up substantially, and much of that appears to be smoking by young people, plus more intense smoking. So the Chinese patterns might well be worse than we had projected. Okay, well, what's the solution to this? The most important solution is taxation. And a surprising example of the success of taxation actually comes from France. You don't think of France as a typical leader in tobacco control, but they actually have been. And as an example, they have their consumption of cigarettes per adult per day from about 6 to 3 in 15 years. And by contrast, in Canada, we halved our consumption from about 11 cigarettes per day down to 5, but it took us 30 years. So how were they able to do it faster? Well, the main reason is because Jacques Chirac, then the French president, raised the prices substantially every year, well above the rate of inflation. And that substantially raised the price, dropped consumption. And here you see the stagnation that's occurred both in consumption and in the price. And this is Nicolas Sarkozy coming in as finance minister and then as president. Carla Bruni didn't have anything to do with it, by the way. She did quit smoking, I should add. And we hope that François Hollande will actually take this taxation levels back up. What's been the net impact of that? Well, prior to 1997, lung cancer rates in young men, and women, which is a good indicator of recent exposure to smoking, were actually going up in France, in contrast to the huge declines in the United Kingdom. And even in women, they were going up. But after 1997, look what happened. That large tax hike and the big decrease in cigarettes per adult has led to a substantial decrease in lung cancer mortality rates at younger ages. And the female epidemic, which was going up, has stopped going up. So France has shown that actually you can achieve enormous reductions in tobacco consumption simply with higher prices. Okay. Well, what are we doing about this in India? I mentioned the million death study. Well, we're doing, I think, an interesting study where we're trying to both generate that kind of national evidence on tobacco taxes. And for example, next week will be the budget that Mr. Chidambaram, the finance minister, will bring down. We've submitted a brief which points to all of this evidence and argued for a large increase in cigarette tax in particular, and we'll see whether he implements that. But in addition, what we're doing is taking the evidence from the million death study and generating report cards for all 600 districts of India. Districts are small administrative areas each with 2 million people. And what we've done is randomize the distribution of this information. So the report card on tobacco will go to half of the country, and the other half will not get any intervention. And as far as I know, this is one of the few randomized trials of politicians, because this actually goes to the members of parliaments and the members of the legislative assemblies. And we will monitor whether there are changes in quit rates from various surveys. So this is an application of epidemiological knowledge to see if interventions can actually have an impact. Okay, let me conclude by showing this comparison again, and this extraordinary change in survival, first for children but now for adults, that is still underway. And come back to my conclusions, which are that the ongoing improvements in survival really are a product of technology and research. And I hope I've shown you 3 examples of where those are widely practicable. I'd like to thank the many collaborators in the Million Deaths study that have worked with us. And if you'd like more information, certainly this is all available on our website. Thank you.